So now, moving on with the word of the ultrasonographer, let's welcome Dr. Giulia Monaco from the team of Professor Caterina Exarchustos to talk about we need standardized criteria. The floor is yours. Good morning.
Thank you for the presentation. First of all, I would like to thank all the organizer and also my Professor Exarchustos for giving me the opportunity to be here today. It's a great honor for me. I would like to start my presentation with the question, why we need standardized criteria? As we can see in this work of 2019, anatomic uterine abnormalities are associated with worst pregnancy outcomes and obstetric outcomes, such as recurrence pregnancy loss, miscarriage, and ectopic pregnancy. In particular, T-shaped uterus seems to be associated with subfertility, recurrent miscarriage, and the metroplasty, the hysteroscopic correction, seems to be the gold standard. But we have only observational studies and no randomized control trials. And the other question is, how many types of dysmorphic uterus do we know? In this video article by Alonso Pacheco of 2019, he proposed a subclassification of dysmorphic uterus in 3 categories. T-shaped, characterized by the thickness of the lateral uterine walls with a normally located tubal ostium that is not visualized unless rotating the hysteroscope. Y-shaped, characterized by thick lateral walls, fundal septum or subseptum, and reduced intraosteal distance, giving the uterine cavity the Y-letter appearance. And I-shaped, characterized by very thick lateral walls and severe reduction of the intraosteal distance. In this panoramic hysteroscopic view, we can see the thickening ring-like structures of the lateral uterine walls extending from the internal cervical ostium to the level of the fundus. Concerning the T-shape, the first time that we mentioned this dysmorphic uterus is in 1988 with the American Fertility Society classification. And it is included in the 7th class that is drug-related anomalies. So the anomalies associated with the use of the ethylsylbestrol during the pregnancy. In the first ultrasound classification of Salim of 2003, but also in the most recent classification of ISRM Mullerian anomalies of 2021, dysmorphic uterus are not mentioned. In 2013, the ESHRE-SJ classification recognized the importance the clinical importance of this dysmorphic uterus and includes this dysmorphic, as we said before, in the class U1. That is divided into 3 categories, U1A, T-shape, U1B, infantilis, and U1C, the others. But it does give us ultrasound criteria. The first ultrasound criteria are in 2015 with this article of Exarchustos, where she proposed 3 ultrasound criteria for the diagnosis: a lateral indentation angle less or equal to 140 degrees, cavity width ratio more or equal to 5, and lateral bulging more or equal to 5 millimeters. The presence of at least 2 criteria is suggestive for a T-shaped uterus. And, of course, the best-known classification of 2020 of Kuhn classification, as we have said before, the 3 parameters. The presence of all the 3 parameters identifies a T-shaped uterus, and the presence of only 2 identifies a borderline T-shaped uterus. In 2021, Alonso Pacheco proposed a simple 3D ultrasonographic method for the diagnosis of T-shaped uterus that is called the rule of 10. So, if the intracavitary line parallel to the interosteal line at 10 millimeters from it is less or equal than 10 millimeters, we can make a simple diagnosis of T-shaped uterus. But as we can see, there is not a consensus yet between the ultrasound classification. In our gynecological center of Tor Vergata in Rome, so in this context, we made a retrospective study. We collected 50 stored 3D transvaginal uterine volumes of women with a subjective diagnosis of T-shaped uterus, And we made an hysteroscopic diagnosis based on the presence of an increased distance between the tubal ostia, a narrow uterine cavity, or an abnormally elongated cervical canal. And all the doubtful T-shaped uteri with a fundal indentation were excluded. And we compare current classification for T-shaped uteri. We can see that in our study population, the 8% of the uteri fulfilled all the 3 Kuhn criteria, the 60% fulfilled the rule of 10 criteria, and the 62% the Hexacusus criteria. Then we try to mix the current classification to identify some independent predictors for the diagnosis of T-shaped uterus. And in our study, these are the results. So the rule of 10 less or equal to 10 millimeters, the lateral bulging more or equal to 5, and the ratio more or equal to 5. And the presence of at least 2 of these 3 criteria was present in 96% of our study population. So, we talked about T-shaped. That is a uterus characterized by thickness of the lateral uterine walls with a normally located tubal ostium. And we have to differentiate this type of dysmorphic uterus from the Y-shaped. That is a uterus characterized by thick lateral walls, fundal septum or subseptum, and reduced interostial distance. We know that also Y-shaped, it's an ill-defined entity. In the last years, there are a lot of definition for the diagnosis of Y-shaped, such as the Alonso Pacheco 1 of 2019, but also in 2022, it was described as a narrow uterine cavity due to thickened lateral walls and a fundal indentation less than 50% of the uterine wall thickness, with a correlation of 2/3 uterine corpus and 1/3 cervix. And very recently, in 2024, on March, it was published a proposal for diagnostic criteria of Y-shaped dysmorphic uterus based on 3-dimensional transvaginal ultrasound measurements. And these are the measurements that have been proposed. In this context, also in our center, we decided to make a retrospective study. We collected 20 stored 3D transvaginal uterine volumes of women with Y-shaped, and we compared to 40 septate uteri, divided into 20 with a wide septum more than 90 degrees and 20 with an acute septum less than 90 degrees. Then we decided to select the 20 with a wide septum because the morphology of this type of septum and the morphology of the cavity is similar to the Y-shaped. And then we compared to 40 T-shaped uteri. And these are our results. So, comparing the 20 Y-shaped uteri with the 20 septate with a wide septum, significant differences are highlighted in the cavity measurements, so in the ratio, in the lateral bulging, in the indentation angle, and in the rule of 10. And non-statistically differences emerged in the septum measurements. And these findings, these preliminary findings, indicates that Y-shaped have a narrower cavity and thicker lateral walls than septate uteri, but no differences on the septum. Comparing instead 20 Y-shaped with 40 T-shaped, no significant differences emerged in the cavity measurements, demonstrating that both have a narrow cavity, and the only significant differences in our study group was in the indentation angle, that is statistically larger in the Y-shaped than in the T-shaped, and obviously for the septum measurements. Analyzing the reproductive outcomes in our study group, Y-shaped presents similar reproductive outcomes to septate, while T-shaped seems to be associated with a higher risk of primary infertility. So we can say that Y-shaped are dysmorphic uteri with characteristics in common both with T-shaped and septate with a wide septum. And the most important parameters in our study were the T-shaped measurements associated with the septum thickening more or equal to 5 millimeters. So to conclude, we can say that today there is not a consensus on ultrasound criteria for the diagnosis of dysmorphic uteri. The identification of standardized ultrasound criteria could help to identify the impact of this malformation in the general population and obviously to study the obstetric outcomes. And the identification of 3D standardized criteria could help to diagnose this type of malformation to ensure the correct treatment. Thank you for your attention.